mentorship's a two-way street, and it is such a rewarding thing because what it does at its core is bring back the community.
Welcome to Off the Chart, a business of medicine podcast featuring lively and informative conversations with healthcare experts, opinion leaders, and practicing physicians about the challenges facing doctors and medical practices. My name is Austin Luttrell. I'm the assistant editor at Medical Economics, and I'd like to thank you for joining us today. In this episode, we'll hear about leadership and the future of osteopathic medicine as Medical Economics senior editor Richard Piccinini sat down with Dr. Robert Piccinini, an adult geriatric and forensic psychiatrist who was recently installed as president of the American Osteopathic Association. They discussed his journey into psychiatry and private practice, what it means to be the first psychiatrist to lead the AOA, and his vision for strengthening physician mentorship, supporting first-generation medical students, and improving mental health resources for physicians. Dr. Piccinini also shared his perspective on integrating behavioral health into primary care, addressing the physician shortage, and the role that artificial intelligence plays in all of this. Dr. Piccinini, thank you again for joining us, and now let's get into the episode.
I'm Richard Piccinini, reporting for Medical Economics. With me today is Dr. Robert G.G. Piccinini. He's an adult, geriatric, and forensic psychiatrist, and the newly installed president of the American Osteopathic Association. Thank you for joining us today.
Thank you, Richard.
And certainly congratulations on your installation.
Thank you very much.
Just to begin at the beginning, so to speak, can you introduce yourself and talk a little bit about your own background and experience?
Well, as you said, I'm a psychiatrist located here in Michigan, and I am a proud graduate of Michigan State University College of Osteopathic Medicine. I graduated in 1992. I did my residency for psychiatry at Henry Ford Hospital down in Detroit. Prior to that, I did a rotating internship in internal medicine at Flint Osteopathic Hospital prior to going to Henry Ford. I went to the Medical College of Wisconsin to do my fellowship in forensic psychiatry. Been in private practice. Initially, I came back after that was done. I worked for a hospital group, and then I went into private practice and have been such for approximately now just about 25 years.
Congratulations on that tenure, only because private practice can be a tough row to hoe in the economy that we have, the healthcare economy.
You definitely learn to take the ups and downs and roll with the punches.
In your inaugural address, you had a lengthy list of thank yous that you wanted to include, and it really felt like you wanted to address what seemed like a whole community of support. I wanted to ask why that is so important to you as a physician and how that informs your practice of medicine and your leadership style.
You know, I really appreciate that question because it's a multi-layered, because one, nobody rises to be a physician without the help and mentorship of somebody. Growing up, I remember the stories of my grandparents telling me of different members of our family that strive to make things better for their children and their children, and, you know, a long generational thing. So, you know, growing up, family was always there supporting you. And then nobody definitely rises to the level of president of the AOA without a lot of mentorship and a lot of support from all different people.
Every doctor we know is incredibly busy, of course, and sometimes it might be hard to reach out to colleagues when your first priority is your patients. If there are some physicians out there, especially practicing physicians, who might want to reach out to some of their younger colleagues and maybe medical students, what advice would you give them?
It takes 30 seconds to ask somebody how they're doing in the day. And that itself can be a mentoring experience. It doesn't take, you don't have to have a special skill set. You just need sincerity, empathy for when somebody's having a rough time, maybe some self-reflection about your own hard times that you went through that you can possibly pass on to somebody. And mentorship is a two-way street. I ask my younger colleagues and medical students when I'm teaching, what's the newest app to use? How do you do this? How do you do that? Mentorship's a two-way street, and it is such a rewarding thing because what it does at its core is bring back the community. And we know with mental health, and we know with society at its heart, it's really what we need is the sense of community to weather the pitfalls and the ups and downs. Because again, if you're isolating yourself, if you don't have those connections, you're at higher risk for burnout. You're at higher risk for depression or anxiety. So mentorship is both a gift and a necessity in our profession.
I really am grateful for you taking the time to share some thoughts on leadership here. And I that is something that we try to, I've had doctors who've told me that, every physician is trained to be a leader. It emerges in different ways. I was curious about, in your inaugural address, you talked about leading with strength and humility. What does that mean in the medical profession?
Well, I think it means accepting the fact that we don't know everything. And that sometimes the humility part of it is reaching out and saying, I don't know everything. I need to search for the answers. And sometimes searching for the answers means going to somebody else and asking them. Yes, it's sometimes easy to look it up, but there's not, it doesn't always mean finding that information in the book. So strength comes when you accept that you're just like the next person, and you can lead through strength by showing the fact that you need to be able to outreach to others that collectively we can succeed. Now, you can't do it all on yourself, and accept that and move forward.
In your inaugural address, you had talked about some of the, shall we call it, nuts and bolts logistics of running the association. And you mentioned specifically about wanting to improve communication among AOA and its member physicians. How do you intend to follow through with that?
Well, I mean, the other thing I spoke about in my inaugural speech was mining the gap. And that is something that, if you're familiar with the London subway, you see the signs, and you hear the statement, mind the gap, and it speaks the distance between the train and the platform, and not to fall in between or have a misoccurrence. And I think as osteopathic medicine has rapidly grown, which is wonderful, sometimes when we grow with speed, we forget not to take along with us some of the things that we necessarily need to do to make sure that our growth is sustainable and on firm footing, so to speak. So I think at times we assume, and this is both a association trait and a human trait, we assume that somebody else is hearing our message or understand our message, but we never circle back to make sure, well, did they hear the message? Did they get the message? And do they have questions about the message? So I think as an association, it behooves us to make sure we're circling back and making sure all members feel connected to the association, that they're hearing the message, and that they have input into the message, so that it is a collective where we want to go, not just where a few people want to go and trying to bring everybody else along. Is there a shared vision of our membership as a whole of where we need to go?
Say, Keith, this is all well and good, but what if someone is looking for more clinical information?
Oh, then they want to check out our sister site, PatientCareOnline.com, the leading clinical resource for primary care physicians. Again, that's PatientCareOnline.com.
Also, as part of the issues, with the association, you had mentioned about addressing the Certifying Board Services Reform. How does the certification process happen now, and what would you like to see in improvements?
The certification is very similar, both on the allopathic side and the osteopathic side, in that you take a series of exams at designated times. And in the past, obviously the osteopathic boards and tests look at the distinctiveness and have questions of distinctiveness within the osteopathic profession and how we approach patients, the whole person treatment of patients, and how our principles and practices integrate into our board exams. But again, circling back to the communication aspect of that, is I think we can do so much more in preparing our students and residents for the process by informing them more so and than what we are doing currently. I think we allow, in the past, it's sort of, at least when I was a student and resident, you kind of asked the next person, what's the process? And then you kind of try to find it out. We need to step up our communication to the students and residents so that they don't have a question. And if they do have a question, it's very clear to them where they can turn for the answers, and make that process easier for them. More so than any time before, there's a lot of stress in medical school and in residency. There's a lot of things happening in their lives. Any way we can make it easier, that's one less anxiety point, we should be doing it. And so that's where I think we can step up our certifying board services, our communication, and helping them educate exactly what the boards are for. Sometimes there's misconceptions that as medical students, you have to score a certain number on a test to be able to be considered for X, Y, and Z, when that really isn't what it was designed to do. Your board certification as a resident wasn't designed to get you a job. It was to certify that you've reached a position of excellence so that the states could give you a license, not necessarily that you would get a job at X, Y, and Z facility.
Doctor, you make a great point and a great segue to a question I wanted to ask about for medical students and young physicians, because this was something that you also emphasized in your inaugural address. Can you discuss your own experience as a first-generation American and the first doctor of osteopathic medicine in your family? And why is that so influential in your presidential initiative to really nurture those first-generation DO students?
Yeah. I remember a time in my life very clearly where we were at home, and it was a summer day, and my parents called me out to the backyard, and my mom only had a high school education. My dad a sixth grade education in Italy, and they said, we know you want to be a physician, and we don't know how to help you. We don't know how to guide you. We'll always be there to love you and support you, but that's something you're going to have to figure out the other half on your own. And were there some missteps? Yeah. Was it difficult? Definitely. And possibly by focusing on what the first generation students go through, and making that pathway smoother with a lot less bumps, is something that is important to me, because I don't want them to necessarily go through the same bumps I went through. And being the first osteopath in my family, it's funny when I go to Italy. For a while, they're explaining to them what an osteopathic physician was, you know, because they have osteopaths, which only do manipulation in Italy, but they don't have osteopathic physicians at the time. So, who are trained in the American form of medicine and that. So, explaining, no, I'm not an osteopath, I'm an osteopathic physician, and, explaining those things to them, but then also taking pride in the fact that I was charting a new course, like, my parents did, as, my father as an immigrant, my mother as a first-generation American, and her family, and doing the things that they had to do. So as hard as it was for me, so much harder for them coming over to a country with no language. And that is, I often think of, a pure first generation student who English may not have been their first language. Those things that they have to go through, can we make it easier so that they can succeed and take that skill set back to their family and their homeland, or even their their community where they're living, and really providing health to that group in an osteopathic way.
In your speech, you mentioned your experience of evaluating more than 10,000 suicide attempts. Regarding physician mental health, how would you describe the current state of professional support for physicians who may be struggling, and what would you like to see improve?
So, the current state, I think I would say is not that great. I don't know how else to say it. It's not that great. It's usually one off. It's oftentimes, I've evaluated physicians, but it's something that they prefer not to do, because they don't want to have a licensing impact on their licenses. Some states still ask questions about their mental health, which I think is a hindrance. And I've spoken to the Federation of State Licensing Boards chair about that. I think that, eliminating barriers to seek help is the first thing we can do. Normalizing the fact that as humans, we go through ups and downs. I mean, you couldn't expect a physician who loses a patient. You spoke that medical economics speaks a lot to primary care doctors. Well, you may have a patient who has been a patient of yours for 20, 30, maybe even longer amount of years. They're your patient, but they become a part of you. You know their stories frontwards, backwards, and sideways. And when they pass, that's going to take a hit on you emotionally. I don't know any physician who it doesn't, when they lose a patient just due to the fact that the patient passes away. It's a personal, even if it was nothing done inappropriate or wrong, it's just the process of being human. We pass, and that's going to be an emotional hit. To be able not to be able to reach out and talk about those emotions to somebody, or seek help if you're having a trouble with that, is a hindrance. And that affects the patients down the line. So if we don't seek help for ourselves, if we're not able to seek help for ourselves, we're actually putting our patients in our community in a worse situation. So we have to recognize that we are human beings, and we are subject to every both positive and negative aspect that can possibly happen to our patients. And to accept that somehow we don't need or require the same amount of help is just a fallacy. So first, acknowledging that fact. Second, then making information more accessible, easy, and appropriate. And then taking away barriers that exist currently today and that might be existing for whatever reasons they were put up in the past. It doesn't necessarily make sense to have barriers today to seeking help.
One of the questions that now comes up, I'll switch gears again slightly because this is a question that comes up in literally every interview, of course, because of the change in administration earlier this year. Currently, the administration of President Trump and HHS Secretary Kennedy have begun the initiative to make America healthy again. How would you like AOA and osteopathic medicine to play a role in that?
Well, I think some of the things that are proposed in Make America Healthy Again fit right into our food as medicine concept that AACOM has proposed. We have always looked at lifestyle, nutrition, the whole person care. So I think in some ways that fits right into our philosophy as osteopathic medicine. I also believe that we do believe in thorough research and studies into treatments, and would never want anything to take that away. So I think we can advocate for continued research and thorough vetting of research, but also I think as osteopathic physicians, it's in our philosophy to be as healthy as possible. And some of those things of nutrition, health, whole person care fits right into it.
Hey there, Keith Reynolds here, and welcome to the P2 Management Minute. In just 60 seconds, we deliver proven, real-world tactics you can plug into your practice today, whether that means speeding up check-in, lifting staff morale, or nudging patient satisfaction north. No theory, no fluff, just the kind of guidance that fits between appointments and moves the needle before lunch. But the best ideas don't all come from our newsroom. They come from you. Got a clever workflow hack, an employee engagement win, or a lesson learned the hard way? I want to feature it. Shoot me an email at kreynolds@mjhlifesciences.com with your topic, a quick outline, or even a smartphone clip. We'll handle the rest and get your insights in front of your peers nationwide. Let's make every minute count together. Thanks for watching, and I'll see you in the next P2 Management Minute.
Again, another great segue to a point that I don't know if you'd call it emerging or perhaps already existing within healthcare right now, but I know there's been some discussion across healthcare about the best ways to integrate behavioral health services and mental health services and primary care. How would you discuss or describe the cooperation between primary care and mental health care, and what are some strengths? Maybe what are some areas of improvement?
I think, well, in my own career, when a lot of my family practice colleagues would call me up and say, "Hey, I'd like to do a curbside consult with you. I have a patient who," they would give me the statistics and say, "I really like them to see you, but you might be booked for 2-3 weeks or maybe longer. But what can I get them started on, and then have them follow up on you?" Or some patients may say, "I just don't want to go see a psychiatrist. I'd rather, can't you as the primary care physician treat me?" And my colleagues would call me up and we'd review the case, and I'd give them my thoughts and where they should go. And to me, that was, again, extremely osteopathic. Part of the osteopathic medicine training, in that you helped out your colleagues, you work as a family together, and so having that ability to not feel like you have to be out on the ledge, just, out there kind of doing what you think is best and maybe not being able to reach out to somebody. Again, oftentimes we think mentorship is, older physician to younger physician. It's not necessarily that way either. It can be, physicians at the same, you know, chronological age or practice level, or, attending to attending. That's mentorship, because I might tell them something about, hey, with X, Y, and Z drug, you just need to watch out for X, Y, and Z, or this is a great population to use this one or that one. That give and take that exists, especially from what I've seen in osteopathic medicine among colleagues, is where I think where we can fill the gaps of what's lacking, as opposed to, oh, well, I can't touch you at all from a primary care. I can't deal with your mental health because you have to go see a psychiatrist, which might, depending on where you're at or how long, or reimbursement reasons, might take 4, 6, 8, 12 weeks, or however long to see that specialist. Is there a way that we can fill the gaps and be more community based, in the sense of the community of physicians, and that give and take would help promote, both make our primary care physicians feel more comfortable if they had an outlet source from a pure. I mentioned earlier, I've been in private practice. From a pure business sense, if I can, you know, I have patients, but I also have customers such as primary care doctors. If I'm helping you out now with a difficult case, who do you think you're going to refer to when you can refer to me? Right? So it was both smart business. It fit into the osteopathic medicine training of community, and it just seemed natural. So I think that's where we have to go, is rediscover our community, in which not do the very segmental silo approach that we have in medicine. If you have X problem, you need to go here. Well, it may take you to so long to get there. Really, is there a way to kind of move that treatment along?
You know what I was going to say? Another great segue, because this deals with not only, I think, that sense of community that you talk about, or perhaps communication and interaction, but and thank you for touching on the business side too, by the way. But I am curious about your thoughts about, just in terms of sheer numbers, given the shortage of physicians, whether it be in primary care or any specialty, what policies or actions would you like to see to increase the number of physicians generally?
Well, obviously, if we can help with GME, or graduate medical education funding, so that we can get more residency spots um, for training of physicians, um, and ideally, enhancing payment to primary care physicians, um, that would help a great deal. I mean, many of our students are picking their specialties, one, both because of the desire and an interest in a certain specialty, but out of the pure practical sense that if they're walking out of medical school and residency, with 3, 4, or $500,000 in debt, the students are not unintelligent. They're going to pick a specialty in which they can pay that off. And the lower numbers that you see in primary care are not one that's making them run to it if they're looking at a $500,000 ticket that they got to pay off over the next 20, 30 years. It's basically, you're going to get a mortgage for your house and you have a mortgage for your education. Um, you can't blame them. So if you want more, and we definitely need more primary care, we have to fund it properly, and we have to make those spots available.
Doctor, if I may, I'll shift gears just slightly, because I am curious about really curious about your perspective on this because, and this is another question that now comes up in every interview. I call it the technology question, frankly, the AI question, because artificial intelligence has really exploded across healthcare and all kinds of different sectors. AI has been suggested as a substitute or surrogate for professional counseling. As a psychiatrist, what are your thoughts on how AI should be used specifically for mental health treatment?
But these are my personal opinion that the human interaction can never be replaced by a computer. There's too much. You have to be too nuanced and nimble that AI can't be the primary source. So I am all for not allowing AI to be your therapist. As a physician and the rapidly flood of information that we are gaining in medical research, AI can be used as a substantial tool in helping curate information and things that I can then disseminate whether or not they're applicable to that patient's situation. But it should never be the primary source. It should always be an adjunctive or augmenting source for what I'm trying to do in the mental health treatment. And I know, AI is a learning model and it grows and it improves. I just don't see that it's going to improve to the point where, or should improve or be used to the point where it ever substitutes that human connection. That itself is a treatment modality. Being connected and having contact with a human being is so important in the development of our mental stability. That just like we see in babies that imprint to their mothers and their fathers, their voices, we see that you can't substitute that. Early on we would say don't use an X-ray to make the diagnosis or to make the diagnosis. Use an X-ray to confirm a diagnosis. So it just I'm trying to keep my answers higher level than just AI shouldn't belong in the role of a primary treatment model. It can be there as an adjunctive or augmenting use, but I don't think it should ever be the primary.
Our main audience is primary care physicians. What would you like to say to them, or what would you like them to know?
I first want to congratulate them because they've picked, a hard specialty. I often say I do primary care as a specialist because as a psychiatrist, we see people at their base level. But I understand, the trials and tribulations that they go through. The thing I would say is, you don't have to do it alone. Even if you're in a small town and you're the only doctor in that town, we and the osteopathic profession especially would love to help them build communities in which they can contact others, communicate with others, be connected both in both the sphere of your town, your specialty, your community, or in this specific way, the osteopathic profession. We welcome all physicians into osteopathic medicine. And we have, our association is built on the fact that, it's a community, it's a family. We're having we have some great educational conferences. That what strikes me is the sense of community. When you attend those, no matter who you are, when you attend those conferences, you can feel the osteopathic community, the osteopathic medicine community that is there. And it's a welcoming community. And that's based on a sense of really just trying to grow and be connected. So what I would say to primary care physicians is don't ever lose that connection with the people around you. Don't ever feel like you have to do it on your own. There's always people out there that you can reach out to toss ideas or, throw difficult cases at them. It's a matter of for our own health and wellness as a physician community to go forth and make sure we're doing just that. We speak of physician communities. We need to make sure we're building the community. And, I'm sorry, I'm going off on tangents here as I think, but that to me is the striking point. And that's why being an osteopathic physician, I feel so good about our community in which we have developed and we continue to develop. And we're just building a bigger tent for all of medicine. And we would love all of medicine to come and join the osteopathic community.
I'm Richard Payerchin, reporting for Medical Economics. My guest today has been Dr. Robert G. Piccinini. He's a psychiatrist and the newly installed president of the American Osteopathic Association. Doctor, it's been a great conversation. Thank you so much for taking the time.
Thank you. I appreciate it.
Once again, that was a conversation between Medical Economics Senior Editor Richard Payerchin and Dr. Robert Piccinini, President of the American Osteopathic Association. My name is Austin Luttrell, and on behalf of the whole Medical Economics and Physicians Practice teams, I'd like to thank you for listening to the show and ask that you please subscribe so you don't miss the next episode. You can find us by searching Off the Chart wherever you get your podcasts. Also, if you'd like the best stories that Medical Economics and Physicians Practice publish delivered straight to your email 6 days of the week, subscribe to our newsletters at MedicalEconomics.com and PhysiciansPractice.com. Off the Chart, a business and medicine podcast, is executive produced by Chris Mazzolini and Keith Reynolds and produced by Austin Luttrell. Medical Economics, Physicians Practice, and Patient Care Online are all members of the MJH Life Sciences family. Thank you.